Hello and welcome to What the FFICM. In this episode we're going to talk about Propofol Infusion syndrome. This is a rare but very serious and potentially fatal adverse effect which occurs after using propofol as an infusion. Although it's traditionally associated with paediatric patients, as awareness of the condition has improved, there have been an increasing number of adult patients also identified. So what is Propofol Infusion syndrome? Sometimes also referred to as propofol-related infusion syndrome, or PRIS. Well, it occurs when a propofol infusion causes an acute refractory bradycardia leading to asystole in the presence of at least one of the following: a metabolic acidosis with a base excess of less than -10, rhabdomyolysis or myoglobinuria, lipemic plasma, or an enlarged or fatty liver. The incidence of propofol infusion syndrome has been shown to be around 1%, with the onset occurring a median of 3 days after starting a propofol infusion. Metabolic acidosis is common in the ICU for a large number of reasons, and with the obesity epidemic, the incidence of non-alcoholic fatty liver disease is also increasing rapidly. This means it can be difficult to diagnose propofol infusion syndrome, and so a high index of suspicion is required, particularly in high-risk patients. And preventative strategies should also be employed. We'll talk about these later. So what causes propofol infusion syndrome? Well, the underlying pathophysiology is an impairment of mitochondrial oxidative phosphorylation and also mitochondrial free fatty acid use. This occurs because propofol has direct effects on mitochondria. Firstly, it indirectly inhibits an enzyme which transports long-chain free fatty acids into the mitochondria. And secondly, it causes an uncoupling of the electron transport chain, meaning neither short or medium-chain free fatty acids can also be used. Free fatty acids are an essential fuel for myocardial and skeletal muscle under fasting or stress conditions. What this means is that there is an imbalance between energy demand and supply within the mitochondria, resulting in lactic acidosis and ultimately skeletal and cardiac myocyte necrosis. There are also two additional factors which contribute to the development of propofol infusion syndrome. Firstly, an increase in plasma-free fatty acids. This is due to the fact that the mitochondria are unable to use these free fatty acids, and also there may be a degree of lipid overload from the propofol infusion itself, and possibly also from TPN infusions. The free fatty acids in the plasma are very pro-arrhythmogenic, and so this contributes to the cardiovascular instability. Secondly, propofol has a direct myocardial depressive effect. This is due to beta receptor antagonism, and propofol also binds to calcium channels, both of which further depress the cardiac function. What are the risk factors for propofol infusion syndrome? Well, these can be broken down into 3 categories. Firstly, the cumulative dose of propofol. Secondly, increased lipolysis. And thirdly, metabolic factors. In terms of the dose of propofol, well, a prolonged duration of infusion, i.e. more than 48 hours, increases the risk, as does the use of a high dose infusion. High dose meaning more than 5 milligrams per kilogram per hour. In terms of increased lipolysis, well, a low carbohydrate intake will stimulate lipolysis in order to generate free fatty acids for respiration. Also, the release of large amounts of endogenous catecholamines or glucocorticoids will stimulate lipolysis, and therefore patients who have suffered burns, head injuries, or who have systemic sepsis are particularly at risk. Similarly, exogenous catecholamines such as noradrenaline or adrenaline and steroids such as hydrocortisone increase the risk of propofol infusion syndrome, and these are very common treatments in the ICU. In terms of metabolic factors, well, young children are very at risk, and this is due to the fact that they have low glycogen stores and they also have a high dependency on fat metabolism. And lastly, but very rare, are inborn errors of free fatty acid oxidation. So how does propofol infusion syndrome present? Well, a large number of patients present with cardiac dysfunction, and one of the earliest features is a Brugada-like ST elevation in leads V1 to V3. So this is a convex ST elevation. Any number of arrhythmias or conduction defects can also occur. A similar proportion of patients also present with metabolic acidosis, and this is due to a combination of renal failure and lactic acidosis. Around 45% of patients present with rhabdomyolysis, and this causes renal failure, myoglobinuria, and hyperkalemia. And lastly, about 15% of patients present with a hypertriglyceridemia, which causes a lipemic plasma and hepatomegaly due to acute hepatic steatosis. Something that is also commonly associated with propofol infusions is the presence of green urine, as you can see in this catheter bag here. The chemical formula of propofol is 2,6-diisopropofenol, and it is metabolized in the liver to form inactive metabolites which are then renally excreted. About 70% of propofol undergoes glucuronide conjugation, and the remaining 30% is hydroxylated by the cytochrome P450 system, and the subsequent metabolites then undergo conjugation with either glucuronide or sulfate. It is these phenol derivatives which are responsible for the green discoloration of urine. However, green urine is a benign phenomenon and is not associated with the development of propofol infusion syndrome. What can be done to prevent propofol infusion syndrome? Well, the first thing is to minimise the cumulative propofol dose. Secondly, it's important to carry out frequent monitoring. And thirdly, you should ensure that your patients receive an adequate carbohydrate intake. In terms of minimising the dose of propofol, well, infusion rates should be less than 4 mg per kilogram per hour, particularly for long-term sedation. And where possible, prolonged infusions should be avoided, so that would be more than 7 days. In particular, prolonged use should be avoided in children less than 16 years, ideally no more than 48 hours. Daily sedation breaks should be undertaken in order to assess a patient's readiness for extubation and also to minimise the amount of sedation they're receiving. And a multimodal propofol-sparing sedation regime should be used. This might include short-acting opioids such as alfentanil or remifentanil, alpha-2 agonists such as clonidine or dexmedetomidine, and benzodiazepines, which can be useful in some clinical situations, but are associated with an increased risk of delirium. In terms of monitoring, the patients should get regular arterial blood gases, lactate, CK, and triglycerides, particularly if they are high risk. In particular, it's been suggested that daily CK monitoring can be used as an early indicator in the development of propofol infusion syndrome. However, CK can be elevated for other reasons such as seizures or muscle injuries, and therefore monitoring of the trend is important. Lastly, in order to ensure adequate carbohydrate intake, you should attempt to establish early enteral nutrition and to limit the lipid load from TPN. So how can you manage propofol infusion syndrome if it does develop? Well, the first thing to say is that you should have a high index of suspicion, particularly in high-risk patients. And this will allow you to recognise the clinical signs early. The first step of the management is to stop the propofol infusion and to use alternative drugs for sedation. Patients with cardiovascular instability may require support with inotropes or vasopressors. And a carbohydrate source is important in order to suppress endogenous lipolysis. This is as little as 6 to 8 milligrams per kilogram per minute of carbohydrate and can be given in the form of a simple dextrose infusion. Additional management options include carnitine supplementation. Carnitine acts as a cofactor in the transport of free fatty acids into the mitochondria. You may need to consider the use of renal replacement therapy in order to help eliminate propofol and its metabolites, but also in the treatment of rhabdomyolysis and hyperkalemia. And lastly, the use of ECMO can be considered if there is refractory cardiac instability. If you'd like to know more about propofol infusion syndrome, there's an excellent article in BJA Education, and there's a link to this in the episode description below. That's it for this episode of What the FFICM. If you found it useful, why not hit the like button to help others find it? And while you're at it, subscribe to the channel and enable notifications so that you're kept up to speed each time we upload a new episode. Thanks very much for listening, and we'll see you next time.